colleagues and friends. It's really a pleasure and honor to be with you today in this important symposium. And first, I would like to thank my dear colleagues, the organizing committee members, especially Dr. Kamal for inviting me to this symposium. I'll be talking about important practical procedure that we do, which is the image-guided in radiation therapy practice, the IGRT. I have no conflict of interest for this talk. Now, we'll start with the definition and background of the IGRT, the principles that are being used and what technologies that we are using nowadays and possibly in the future, and the clinical importance of the IGRT. Why it is really important to have the imaging process during the treatment or before treatment, because we know that internal anatomy is not always correlated with the surface anatomy, so we need some tool to help us to deliver the radiotherapy to the tumor with less dose to the organ at risk around. So since the first report of verification image in 1962, image-guided radiotherapy has been instrumental in every major radiotherapy developments like techniques, IMRT, BMAT, SPRT, proton therapy, and others. The definition of IGRT came from ASTRO and ACR in 2010, defining this as the procedure that can be understood that refines the delivery of therapeutic radiation by applying image-based target relocalization to allow proper patient repositioning for the purpose of ensuring accurate treatment and minimizing the volume of normal tissue exposed to ionization radiation. And of course, the hallmark of the IGRT is the strategies to manage intra and interfraction motion of the tumors and adjacent organ at risk. Now, the other also practical definition for the IGRT, that is any imaging at pre-treatment and during treatment delivery stage that will lead to the action which can improve or verify the accuracy of radiotherapy delivery, hence decreasing side effects and improving the outcome with highly accurate and precise treatment, static and moving targets. Now, the approach of capturing and reducing systematic and random errors when delivering radiation therapy also can be done using this technique, the IGRT. Now, it also involves acquiring data that can capture the position of treatment volumes, and it was mentioned in the ICRU report 50 and 62. Now, for the last probably 20 years, a lot of changes have been done for the imaging, starting from portal films that we used in 80s and early 90s, the CT on rails, to the KV imaging, KV com beam imaging with KV and MV com beam imaging. And this is how the development of the imaging during radiotherapy or before, the MV-CT imaging, then the ultrasound, using the ultrasound also as a tool for the IGRT. And nowadays we see a lot of research and some clinical application of MRI also based in the IGRT. And maybe in the future, near future, we will see using the PET or the PSMA or the other agents using as a tool for the IGRT as well. Now, what are the principles of IGR technologies used? We'll start from the portal and radiographical images that have been used before, and then we go to the in-room CT scanners, which started in early 1990s. Then the com beam CT, which is mostly now used in most of the radiotherapy departments, the helical tomotherapy, the ultrasound, and where we can use the ultrasound as the IGRT, and the recent one, the MRI-based IGRT, and hopefully that we may, as I mentioned, near future, see the PET scan as the IGRT tool. For the portal and the graphic imagers, KV X-ray with the X-ray tube is mounted usually in the gantry with an opposing flat panel image detector, and the use of the EBID with its own flat panel image detector has been used, the electrical portal images. And the flat panel image detector in both cases is a matrix of detectors with amorphous silicone photodiodes. KV images, we know that have better contrast than the MV images of the ABIDS. Now, this is the machine that we have been used many years ago using the ABID, the electrical portal imaging device, which we have used for a few decades now, which accurately position radiotherapy patients immediately prior to the treatment and to provide some record of a treatment for physician to review later on. And these are some of the examples of the portal films and digital portal films that have been used mainly in 80s and early 90s. You can see the Kodak therapy localization films and Kodak TV therapy verification as well. Then we moved to port film that which we used in 80s and 90s for head and neck cases and for like seminoma in the left side cases, whether it is paraortic or the inguinal or ipsilateral pelvic, and then to the pituitary adenoma that we use in the low right side here, and the brain tumors. And then also for some of the cases of the breast cancer and head and neck cancer, then we moved to the 2D megavoltage portal film, which was just in time, real time. And then also we moved for the 2D KV imaging, where we use it for many cancers. Now, digital portal films also before cone beam CT was the main one that we used. And this is how we did it with the MLC and how we did the verification film for our record, and to make sure that we are targeting the tumor with the anatomy or with the same setup as the CT simulation. You remember those cases with prostate cancer when we used before, and then move to the three-dimensional megavoltage imaging system as well. Before we started in early 90s, the in-room CT scanner. And it was actually by Omatsu, who was in 1996, the first one in Japan to develop this in-room CT imaging for treatment guidance. And he published this publication, Dual Computer Tomography Linear Accelerator Unit for stereotactic radiation therapy. It's a new approach. From that time, many hospitals and many departments adopted this, where in this technology combines CT scanner with a linear accelerator for radiation therapy, and the CT scanner used to obtain CT images before each treatment. Couch moved in the axial direction to take CT images, and the couch is related back into alignment with the accelerator gantry for treatment. But here, neither the couch nor the patient is moved relative to the treatment isocenter. And these are some of the publications that they used, the early use in 90s about the CT in the liver, and one for the lung cancer as well. And this is a publication again in 2003 using this new CT scan. And these are the films that we use to work on with the CT inside the link to the linear accelerator. If you can remember the head and neck cases, the breast and the rectal cases, or this is the bladder cases, and that is before they used the cone beam CT. Then we entered the era of the cone beam CT, where most of the departments of radiation oncology they have, and most of the machines they have now. It is the technique which integrates the CT images with a LINAC and the image visualization of the exact tumor location, where here the acquiring multiple planar images reduced by both the KV and MV, cone beam rotating 360 around the patients. Filter back projections algorithm is used to reconstruct the volumetric images of the target volume, and this is how we see it during to compare the planning CT with the cone beam CT and to do some adjustments. You can see here some of the cases how really it's important, the image-guided radiotherapy during the treatment to know about the organ, like for example, left side, the prostate case where you have the bladder and the rectum filling is different. And also there is a moving in the BTV here. So you have to do some adjustment, whether clinical adjustment, pre-CT, or just minor. If it is the variation very minor, you can just do repositioning and then treat. And the right side, you can see here the filling of the bladder, the one at the CT sim and one the actual. So here you have to do some action to try to correct this. Not only this, and this is the usual one that the picture of the CBCT that we can use where we can adjust if it is less than 2-3 millimeter. Otherwise, you have to have another action. The other also clinical importance of the IGRT is the adaptive radiotherapy, where really during doing the CBCT, during the treatment, you know about the change in the anatomy, especially the response to radiotherapy in these cases, like in head and neck case, where you see there is a reduction, marked reduction in the size of the tumor. Then in this case, you have really to do a re-CT, and really you have to replan these patients. And you can see here the difference between the treatment the first day and then with the treatment with the response, that the anatomy will change and all the contouring will change, and you have to do a replan. For D also, it's really very important, the IGRT during the 4D, especially when you are considering the SPRT for lung, for example. So we do the 4D CT respiratory motion, and to study that and to generate from the GTV, the multiple GTVs, the inhalation and the exhalation cycles, the ITV, and you just take 3 to 5 millimeter BTV from the ITV. In these cases, whatever you use, especially when you use the hypofractionist in the SPRT and some of the other cases, you need really proper immobilization that can help you as well. So in the modern linear accelerators where the CBCT is there, the MV and KV are there. And here we'll just show you what's the importance and then where we can use it, and what's the difference between the kilovoltage and the megavoltage in the com beam CT. Now in the kilovoltage here, it is the image generated by the flat panel area. Detectors mounted opposite the X-ray tube, and the 3D volumetric images are reconstructed by the computer using a filter back projection algorithm. And on the board, KV imaging system is capable of radiography, fluoroscopy, and com beam CT. And you can see here the difference between the CT, the kilovoltage, and the megavoltage. While in the megavoltage com beam, it's made possible by the use of traditional ABID with a flat panel detector, and the X-ray here, the source in this case is the therapy beam of the accelerator. Now, the planar projection images are acquired from multiple directions as the X-ray source and the detector rotate around the patient. The soft tissue contrast is reduced in the MV CTV as you can see here. Now, what are the advantages of the MV CBCT over the KV CBCT? Is the issue of the susceptibility to imaging artifacts due to metallic objects such as hip implants or dental fillings and surgical clips. And you can see here down in the CT scan taken with the MV without artifact. And there is no need for extrapolating attenuation coefficient from diagnostic KV beams to the therapeutic beam. And here the CT numbers in the MV CBCT correlate directly with the electron density. The known dose distribution characteristics of the therapeutic beam allow more accurate calculation of imaging dose in the MV CBCT acquisition. While the advantage of KV CBCT over the MV CBT is the better contrast and spatial resolution, as you can see here down on the right side in the CT taken, better soft tissue visibility at much lower doses, and compatibility of the KV CBCT images with the reference treatment plan, images for patient setup verification and correction. Combination of radiography, fluoroscopy, and CBCT capabilities from the same source and detector, which provides really a great flexibility in implementing the goals of the IGRT. Now, coming to the helical tomotherapy, this is also one of the machine used in which the IMRT delivery technique that combines features of a linear accelerator and the helical CT scan. Here, the linear accelerator is mounted on a CT-like gantry and rotates through a full circle simultaneous with the gantry rotation. The treatment couch is translated slowly through the donut aperture and creating a helical motion. That's why it's called a helical tomotherapy of the beam with respect to the patient. And this is the construction of the, you can see it, the components of the tomotherapy machine and some of the plan that used by the tomotherapy with a good dose distribution and less to the organ at risk around. Now, coming also, one of the tools that we can use is the ultrasound. And mainly the ultrasound, as you know, it's not radiographical, real-time imaging, can really try to localize the soft tissue structures and the tumors, and mainly use in some of the tumors in the abdomen and also in the pelvis, mainly the prostate. And we have started that in our hospital for the prostate cancer. And there are many systems doing that, which is all of them provides a rapid means of localization of some of them if used for prostate before each treatment and making correction for interfraction variation of the prostate position as an example. It can be done the ultrasound for pelvic, some of the pelvic tumors, abdominal and the breast also tumor, especially if you want to see the seroma and the level of the seroma. These are some of the ultrasound that are in use as an IGRT tool in radiotherapy practice. What about the MRI? MRI actually, a consortium was formed, which called MR-LINA Consortium in 2012 by Electa and Philips, and they involved 300 scientists from 12 institutions, mainly in Europe and in the US. And also they came up with a machine which is really, it is MR-based linear accelerator, and it was approved in Europe in June 2018, and in USA in December 2018, the same year, and the first use at the MD Anderson Cancer Center, because actually MD Anderson Cancer Center was one of the sites in 2012 to try to develop this technology. That's why it was first used there. And the projects actually in the MR based was mainly the MR Linax, MR guided brachytherapy, and MR for proton therapy. And we know in some of the tumors, the MR can show us better images than the CT scan. Mainly if you are talking about the liver lesions, you can see on the left side with the CT or the MRI, how clearly in MRI, for example, the prostate, you can see it in MRI better than CT, and in the head and neck cancer as well. So if we succeeded in having tools like ultrasound, CT, and MRI, and now they are in use, what about the PET scan? Although so far it is not there in a clinical use, but since we used it for the diagnostic and for radiotherapy planning, many cancers now we do the planning, fusion planning, like the lung cancer, like the esophageal cancer, like other cancers, where we fused together the PET and the CT imaging for planning. So the question, why not to do it for the as a tool of IGRT? And I think this area under investigation, maybe in the coming few years, we have a machine, linear accelerators, and with that, there is also the PET facility as well. For these also is really important for the image-guided radiotherapy, because we know, especially for the moving cancer, or moving tumors, that you need a good tools of the image-guided radiotherapy to try to know that to know exactly that you are hitting the tumor with less to the side effects to the organ at risk. Now, clinically important, there are many recent in 2020 at least publication discussing the importance of the IGRT, like the image-guided radiotherapy to manage respiratory motion in lung and the liver, and also the image-guided radiotherapy for pelvic tumors. It was a review of current evidence and utilization, and one also the review of image-guided radiation in head and neck, which really I request all of you to go through this in details. And that is all they agreed that the importance of the image-guided radiotherapy in delivering the radiotherapy with less side effect accurately, especially when we are talking about the SPRT hypofractionation, or we are talking about the dose escalation. So we need really to have the tools to target the tumor with less side effects to the organ at risk around. And these also some about the MRI, the new one 2020 publication about the use of MRI guided adaptive radiotherapy in liver cancer here and in the lung cancer here. To conclude, we really the IGRT it's an efficient and clearly defined set of process protocol needed. And why it is really needed? Because we know IGRT can help us in better patients treatment, more confidence in the treatment, customized treatment, ability to image daily if needed, and less subjectivity, a better image quality, and clearly defined protocols and automated couch movements. So each department should have a protocol of assurance, quality control and assurance to make sure that we deliver whatever we deliver, whether it is CBCT or MRI based or ultrasound, that it should be under a quality control and assurance program for this. And in this regards, education and training for the radiation oncology technologists, for the medical physicists, for even the radiation oncologists, really it is very important. So it's an ongoing process of education and training. By this, I finish my talk. So thank you so much. And I hope that you enjoy the rest of the talks in this session. Thank you.